What we know in many outbreaks and epidemics is the number of people who die from the disruption of normal healthcare may be larger than the number of people who die from the disease itself. It's very important that we expand telemedicine and other ways for people to get care efficiently and well without risking themselves being exposed or further overwhelming or exposing healthcare workers and healthcare facilities.
Well, good morning. I'm Paige Winfield Cunningham, an anchor of the Health 202 newsletter here at the Washington Post. And today we'll be discussing America's healthcare future. My first guest is the president and CEO of Resolve to Save Lives, and he was also the director of the Centers for Disease Control under President Obama. Dr. Tom Frieden, welcome.
Thanks. Good to be with you, Paige.
You know, it's an understatement to say that we're in a real tough spot on the pandemic right now. I know yesterday we had 1,500 deaths, and the sad reality is it looks like COVID is going to be the third top killer for 2020 in the U.S. And I know, we could talk about a lot of different reasons why the U.S. has really struggled to control the virus. But from your perspective, can you kind of talk about what you see as the top factors in the U.S. healthcare system sort of contributing to why we're in the situation that we're in right now?
I think there are overall societal or governmental factors and then healthcare system factors. In terms of the societal response, what we've had really is the failure of federal leadership. Even now, more than 6 months into the pandemic, with more than one American dying every minute, there's no clear national plan, there's no set of objectives, there's no organized response, and there's not specific enough guidance to states. That's despite a lot of hard work being done by a lot of people within the federal government. In terms of the healthcare system, we have so many problems it's hard to know where to start. First, we're not nearly safe enough in our healthcare facilities. In an average year, 70,000 Americans are killed by infections they pick up in the hospital or other healthcare facilities. So we need to make healthcare safer for patients and for healthcare workers. Second, we have a very disorganized system. So it's difficult for clinicians to find out the history of their patients and for patients to get continuity of care when they go from one place to another. And third, we have a very weak primary healthcare system, and one that really isn't based on maximizing health. Really, if you step back, big picture, what do we want from our healthcare system? Not complicated. It's not employment, it's not revenue, it's not profits, it's not employee benefits either. What we want from our healthcare system is health. And yet we don't organize with that principle in mind. And to do that, we will need really a revolution in supporting primary healthcare as the center of our healthcare, so that every one of us can have our own doctor or other clinician who we can rely on, turn to, who knows us and knows our history. Some people are fortunate to have someone like that, and that's great, and that should be strengthened, but way too many Americans don't.
I know that you've, shied away from criticizing too harshly, perhaps the administration or the CDC, but I do want to ask you, do you think the CDC deserves any blame for this? Are there any ways that you would criticize the agency? Or conversely, do you think the agency has been unfairly criticized at all?
Well, both, actually. On the one hand, the failure of the test, and especially the failure to correct the error with the test for 3 critical weeks in February, was a very serious problem, and there needs to be an independent investigation of why that happened and how to prevent anything like that from ever happening again. So that's a serious problem. But there are thousands and thousands of public health professionals working around the clock at CDC to protect you. Americans are voting with their clicks. So we've already had We've seen more than 1.6 billion clicks on the CDC website. It's a stupendous number. And you've still got excellent guidance on the CDC website. Lots of information for individuals, for businesses, for schools, for colleges, universities, healthcare facilities, and other. It remains one of the great public health entities anywhere in the world. But what's happened really is that it hasn't been allowed to do what it does best. It hasn't been allowed to explain to the American people what's happening, explain as we learn what we're learning, and it hasn't been setting the policies. And that's really both unfortunate and unsafe. It's one of the reasons for our federal failure. Blaming the CDC for the US failures is like blaming someone who's been bound and encased in cement for failing to swim.
Do you worry that the response is going to damage sort of the future reputation of the CDC, kind of at a time when a lot of Americans, led by President Trump in some ways, are feeling more hesitancy to believe public health officials?
We've seen unprecedented hostility toward, undermining of, sidelining of public health, not just at the federal level, but in some states and cities and in some places around the world. It's as if the movers and shakers of the world, the politicians and business titans of industry, looked over at public health in the middle of the most disruptive public health crisis in a century and said, nah, we're not going to do that. But if you look around the world at places like New Zealand, Iceland, Senegal, Rwanda, Uganda, the places in the world that were guided by public health and fully supported public health are doing better. They have fewer deaths, they have less disease, and they have less economic devastation. They're getting their economies back faster. Their kids are going to school. We have a way to get through this. It's not by sidelining public health, it's by supporting public health. Public health isn't a blockage in the road to recovery. Public health is the route to recovery.
Right, and to your point, we have seen unprecedented numbers of local public health officials either be forced to resign, fired, retire. Does that concern you when you see those developments at a time when people need to be listening to public health officials?
We definitely need a reset in our approach to public health in this country. There's no doubt that there are weaknesses at every level, federal, state, and local, and some of those are the result of decades of underfunding. And some of those are the result of the difficulty of public health intersecting with our healthcare system. But we need to move forward. We need to make sure that we never again are this underprepared for an emergency. And even in a year when we don't have an emergency, we have outbreaks, we have preventable illness, death, injuries, disabilities. We can do so much more with our public health system. We can be so much healthier. We can go about our lives and reach more of our potential. Our kids can grow up without addiction or obesity. There's so much that we can do if we rely on, invest in, and improve public health. And that's why I think we need to change fundamentally the way we fund public health programs.
Right, and on that note, I know that you have called on Congress to pass a new stream of funding for threats like COVID. Can you tell us a little bit about that and why you think we need another stream of funding?
Having spent many years advocating for more resources for public health, frankly, mostly unsuccessfully, what we've come to recognize is that there are different types of money in Washington. There is what's called discretionary budget, and that has a cap. So long-term support for public health will always lose in discretionary budget cap approaches. There is a mandatory, or sometimes called entitlement funding. That was tried during the Obama administration with the Prevention Fund, and that became a piggy bank for, frankly, both Republicans and Democrats to take money away from public health. So that's not going to work. Then you have supplemental money, and that was tried after Ebola with the Ebola supplemental. And that was really helpful, but it's time limited. And with supplemental one-time money, you can't effectively build programs, you can't hire staff, enter into partnerships, hold companies accountable. So that's not a way to build public health. We need a new way. And that way could be what we've called the Health Defense Operations Budget Designation. And that would have two essential components. One, that it's discretionary but budget cap exempt. That means that legislators don't have to make these terrible choices between, do I fund Head Start or cancer research or Alzheimer's research or protecting Americans from a pandemic that might not happen? In that choice, that last one fails and loses if we don't have a separate designation for that. The second component is what's called a bypass professional judgment. Technical term, but fundamentally it means that it's the professionals at the different agencies, CDC, FDA, maybe agriculture, NIH, provide to Congress what they need in order to meet the vision of a safer America. And for that, you'd then have the Congress and the public able to know what do we need to keep Americans safe, and we can actually do it without having to rob Peter to pay Paul. So this is, we think, a promising approach. There are other approaches, but one way or another, we need to hit the reset button here. It's inevitable that there will be another pandemic. It's not inevitable that we will be so woefully underprepared for the next one.
I want to ask you about something in the news over the last couple of weeks, and that is the way in which hospitals are reporting COVID data to the federal government. And there's been a lot of controversy, as you know, around this new system set up by HHS, whereby hospitals, instead of sending that data directly to the CDC, instead of it goes through a private contractor to a database, which is then going straight to HHS. Can you give us your perspective on that? Is that a good move? Is it solving any problems here?
I think we have to wait and see. It's too soon to say right now. The federal government, the HHS, and the White House have said that this is going to result in a better system. We are seeing a higher rate of reporting. That's undoubtedly related to the fact that when they made the change, they also said you can't get remdesivir, a drug that helps people with severe COVID, unless you report to the system. But what we need more broadly is really a new platform for public health informatics in this country. And that has to be at the federal level, state, local, county level, also has to include all providers. It has to be easier for everyone to use, and it has to be public and transparent. The public reporting of key indicators is enormously important. We need to know our risk, we need to know our response, and we need to know our enemy. And unless we get that kind of reporting nationally and at state and county and city levels, we're fighting this epidemic blind.
Well, and it's been clear that we have had a lot of trouble getting COVID data quickly. It's a real problem, and I'm wondering, what do you think are the biggest data holes right now, both on the federal level and then on the state level?
Well, there's one emerging challenge, and that's looking at the percent of tests that are positive. Turns out that's measured very differently in different parts of the country. For some, it's the proportion of patients tested who are positive. For others, it's the proportion of all tests that are positive. We like the patient's measurement, but most places can't do that yet. But what's changing is the rapid antigen tests. There's the possibility that as those are scaled up, public health will lose sight over how many people are testing and what the results are. That's something that has to be addressed. But to me, the biggest problem, the really biggest problem, the bottom line of our data gap is that we're not looking at our performance. We're not seeing, for example, what proportion of tests are coming back within 24 to 48 hours. We're not seeing what proportion of patients are isolated quickly after they provide a test. We're not seeing what proportion of contacts are warned so they can protect themselves and their families on time. And we're not seeing what proportion of today's cases were yesterday's identified contacts told to quarantined so that the virus stopped with them. These are the most important indicators of the response, and yet very few places anywhere in the country are reporting them. And what gets measured, especially what gets measured publicly, can get managed. And we need to do a much better job managing this outbreak, because if we don't control COVID, COVID will continue to control us.
As I like to tell my daughter, you want to be done with COVID, but COVID is not done with you. But I want to ask you about contact tracing, because I feel like, you know, myself and other reporters wrote a lot about this during the lockdowns in the spring. And I think, at least speaking for myself, you know, we were placing a lot of hope in this idea that through the summer we'd be doing this testing and then we would have the capabilities to do the contact tracing. And it seems to me a lot of that has fallen by the wayside. Do you see any communities in the US really doing contact tracing well? How would you kind of grade that overall?
Overall, we're not doing well. And when there is explosive spread, it's difficult or impossible to do contact tracing well, both because there are so many patients to be interviewed and supported, and because there are so many potential exposures occurring. So in places of the country with 10, 20% positivity rates, really almost everyone has to assume they're a contact. That's why the 3 W's, wear a mask correctly, and one without a valve, wear a mask, wash your hands, watch your distance is so important. Closing bars and indoor dining in those places, that's important to tamp down cases. Once cases get to a lower level, then contact tracing can kick in and be very effective, but it has to be patient-centered. This is not about a call center calling up thousands of people. This is about a disease investigator who has to have the kind of social skills of a social worker, detective skills of a skilled, experienced detective, counseling skills of a psychotherapist, public health skills of an epidemiologist. It's a tough job, and it means building a bond with the patient so that the patient understands, has their questions answered, trusts, and shares information about their contacts. One contact tracer said to us, you know, most of our time is not spent asking questions. Most of our time is spent answering questions. And contact tracing is an art and a science. There are places around the country doing it well. I think San Francisco is doing a good job. There are rural areas with 1, 2, or 3 public health nurses who know their community, who've been doing this kind of contact tracing for decades, who are doing a great job in Michigan, Ohio, and elsewhere. But by and large, this is something that's not being done to the degree it needs to be done. And our organization, Resolve to Save Lives, part of Vital Strategies, works around the world. And what's really striking is how much weaker the US is at this than even countries in Africa, let alone places like Hong Kong and Taiwan, China, mainland, Iceland, Germany. They're all doing this very, very well. It's not a question of quantity, it's quality. It's getting that one-to-one human interaction, making sure that the patient is the VIP of the program, and contact tracing is a way of supporting patients so that they can be safer and they can warn the people that they may have exposed.
You and 4 other former CDC directors wrote an op-ed in the Post recently saying that President Trump has done more to politicize healthcare than any other president. What exactly did you mean by that? And also, do you see any way out of the politicization of all of this?
Well, if you look at the simple issue of mask wearing, masks are really important. And it is true that we didn't know that back in January and February, and there's a reason for that. And one of the casualties of CDC not being able to speak with the American people every day or virtually every day, as I did during the Ebola, Zika, H1N1 outbreaks, one of the casualties of that is that Americans haven't kind of walked down the pathway of understanding that the rest of us have in public health. If you look at diseases that are quite closely related to COVID, SARS and MERS, these are close cousins of this virus. They behave the opposite of COVID. With SARS and MERS, the sicker you get, the more and more and more virus you have in your system. And you're maximally infectious 10, 14 days after you get infected. In COVID, it's the exact opposite. You're maximally infectious before you feel sick. And then after 2 or 3 days of being sick, you get less and less infectious. And by a week or 2 after, you're hardly infectious at all. This is the opposite. And that's why masks are so important. So when public health said everyone should wear a mask, to have the president saying, I'm not going to do that, and making fun of people wearing masks, really, I think, put a very difficult frame on this. Wearing a mask isn't a political statement. It's not in favor or opposed to any politician. It's opposed to the virus. There's only one enemy here. The enemy is the virus. And the more we work together, the more we can fight the virus. The virus really exploits any weakness, any split in society, whether that's systemic racism or the way we treat our elderly, or bad infection control in hospitals, or partisanship. If it divides us, it can conquer us. And the more we unite, the more we all wear masks to protect all of us, the safer we'll all be. But one thing also, there's not one answer here. Not staying home, not banning travel, not wearing masks, not testing, not contact tracing. And as an epidemiologist who's spent a few decades fighting infectious diseases, one of the things that's so frustrating is this concept that if we just do this one thing, we'll be okay. Well, if there is one thing we should do, it's to support and be guided by public health, because that will give us the kind of comprehensive response that learns week by week, day by day, month by month, so we can chip away at this risk and get our economy back, get our society back without risking lives unnecessarily and avoidably.
We started off this segment talking about systemic issues with the U.S. healthcare system, and I'm wondering, do you see any positives coming out of all of this in terms of reforms, ways that we can sort of bring a really fragmented system together? One way I'm thinking of is telehealth, where use of that has exploded. But, you know, I guess to end on a note of optimism, do you see any reforms, you know, sort of getting some steam because of the way the pandemic has affected all of us?
I do think telehealth is a very positive development, and I think CMS has done an excellent job of promoting and allowing that in both Medicare and Medicaid. So I'm encouraged by the growth of telehealth. Telehealth services can be very effective. They have to be structured so that they don't leave anyone out. Older people, people without broadband, people who are less computer literate. But telehealth is a great technology, and it's probably advanced by years in just a few months in the US. I think the greatest potential here, and we should, as the saying goes, never let a crisis go to waste. The greatest potential here is to rethink and restructure how we pay for and support both public health and healthcare. And in healthcare, I hope what we'll see is a transformation and focus on primary care. The data is very clear. We pay top dollar for some of the worst health outcomes of any well-off country in the world. And this isn't because of malfeasance, this isn't waste, fraud, and abuse, this isn't doctors and nurses not working really hard and supporting patients. This is because the structure of our system. We need to pay for healthcare to maximize health, and we need to put primary care front and center in that. And I hope that that will be one of the real impacts of this pandemic, a stronger public health system, a stronger primary healthcare system that keeps Americans safe and healthy.
Well, unfortunately, that's all the time we have today with Dr. Tom Frieden. Dr. Frieden, thank you so much for joining us today.
Paige, thanks so much. It's been great speaking with you.
Please stay tuned, and I'll be back with Dr. Josh Denny after a word from our sponsor.
How do things work? Things that give so much joy and happiness. How can the right support drive optimal health? How can shared intelligence spark brilliant solutions? How can we improve the quality of healthcare and make it more affordable? How do we bring everything together so that healthcare works for all of us? We know how. We are the how. Optum. How well gets done.
Good morning. Welcome, doctors. I'd like to introduce Dr. Omar Baker, EVP of Strategic Initiatives and Innovation at Optum Health, and Dr. Daniel Frank, our Chief Medical Officer at Optum Care. And today, we're going to follow up from Dr. Friedman's discussion, where he said so many problems, but also so much we can do to make it better. So doctors, I think starting out today, let's jump right in. Optum's been speaking about a fragmented healthcare system. And COVID has brought that to light in so many ways and bringing so clearly the gaps to the forefront of our system. Can you address what we're doing about these challenges specifically?
Of course. You know, as you mentioned, COVID-19 has clearly exposed some long understood consequences of healthcare fragmentation more clearly. In a fragmented healthcare system, providers and patients generally don't know what care gaps are critical and struggle to address them. A great example Routine screenings for breast and cervical cancer have dropped by north of 90%, and colon cancer screenings by 86% during COVID-19, increasing the risk of having more severe disease in the future. No doubt, much of these reductions are due to fear and the call to delay non-essential services as we struggled through the early days of the pandemic. But as a coordinated healthcare system, we've been able to react. For example, in Texas and New Mexico, leveraging our data and analytics, we sent over 70,000 in-home colorectal cancer screening kits since COVID-19 begun. Thus far, we've actually received back about 750 of these, which have been abnormal, and we've worked to expedite connecting these patients to care. This is just one example of focusing on clinically necessary gaps in an integrated care network.
And Dr. Baker, what could you add to that for us, please?
I agree with everything my colleague, Dr. Frank, alluded to. I would like to also focus on some lessons learned and challenges that became opportunities during the Optum COVID-19 response. What really became increasingly apparent was the importance of leadership, agility, and making swift decisions in a cohesive, integrated environment to support our front lines during a time where we were being attacked by a vicious and unknown virus. So essentially, it boiled down to a lot of the things Dr. Frieden, former CDC director, also mentioned. The importance of the PCP, primary care physician and patient relationship, was critical pre-pandemic, but really became critical during the pandemic and will be more important than ever on the other side. It's the decisions that those folks make with their pen that will ultimately impact the total cost of care, outcomes, and the patient and provider experience. I'll also say data was critically important to inform our decisions, to protect our front lines and the patients they serve. So having timely, validated, and reliable data was critical. And teamwork. Healthcare is a team sport. So, I would be remiss without giving gratitude not only to the 70,000 frontline clinicians at Optum Care, but frankly across this nation, all the physicians, nurses, medical assistants, respiratory techs. I mean, what we've seen is folks going above and beyond their oath, and just stamina and courage that's really served this nation well, with a focus on science and the patient being at the epicenter of that.
And clearly the need for data, understanding the data is so important. It's not just access to healthcare, it's access to equitable healthcare and quality care, as you spoke about teamwork and going above and beyond. But this crisis has led to people struggling to get access to care. So talk to us about what can be done and what's being done now, so we have an understanding of how it's going to get better in the future.
You'll hear physicians and healthcare leaders talk about the quadruple aim. That is truly our North Star at Optum, which is accessible care, affordable care, driving the best outcomes with the highest patient and provider experience. COVID-19, magnified what were already existing health disparities and inequities. It essentially shined a magnifying glass on what we already knew. So those populations and patients, whether based on demography, race, or chronic disease, were even more vulnerable. So I'll give you some examples of some of the things that we did at Optum and United Health Group. We basically helped target senior and vulnerable populations in several states to increase testing capacity by about 750,000 additional tests. We really focused all of our capabilities in point solutions. Our house calls division, for example, did over 200,000 house call visits just in the month of July to meet our most vulnerable patients where they wanted to be met. And we were also quite philanthropic, giving hundreds of millions of dollars to affordable housing for the underserved and addressing social determinants of health. A lot more work to come, but that is a priority that's really an extension of our cultural DNA and our values.
Thank you for that. Dr. Frank, any quick words to add?
Yeah, maybe I'll just add that it's been mentioned several times during this conversation that during COVID-19, telehealth and virtual visits have been critical. And I think everyone might be surprised how many of our patients don't have access to the technology that they need for virtual visits. So we've been working really hard to source thousands of digital devices and deliver them to our patients most at need. Recently, in the month of June, across hard-hit Florida and Texas, we were able to provide care to an additional 30,000 persons who weren't able to come in and who didn't have access to technology device. So I think just a real testament to what we're trying to accomplish here, system integration, and most importantly to our people, that we know who our patients are and are working to prioritize their care.
Dr. Baker, Dr. Frank, thanks so much for sharing your insights with us today, and back to the team at the Washington Post.
Thank you.
In the middle of a crisis, we may all, like individually or as a society, decide that the government should have far more ability to look into our lives or surveil us or spy on us or take data off our phones and do something about it in the middle of this crisis. But we certainly want to look at that and see if we want to remake our society that fundamentally over time.
Welcome back. I'm Paige Winfield Cunningham, the anchor of the Health 202 newsletter here at the Washington Post. And with us now is Dr. Josh Denny, who's the CEO of the All of Us Research Program at the National Institutes of Health. Welcome to the program, Dr. Denny.
Thank you, Paige. A pleasure to be with you.
Would you give us a quick overview of All of Us and how many people you've enrolled so far? And I'd also be curious to hear whether the pandemic has at all affected your effort to enroll people.
Thank you. Yes, the All of Us Research Program was begun, first opened its doors in 2018 to recruit one of the largest and most diverse populations in biomedical research history, really. Our goal is to enroll 1 million or more participants of diverse backgrounds across the United States. And those participants are partners with us and share data, biospecimens, they answer surveys, they agree to potentially use digital health technologies such as activity monitors. And we also collect information about the environment and life circumstances through those information. So we really can get a full and complete picture of who the individual is and look at their health outcomes. A key part of that is looking at electronic health records and really get a dense understanding of who someone is and their health trajectory so we can better understand disease. So far we've enrolled over 270,000 folks that have completed all the major steps of the program, and over 355,000 have consented to be part of the program.
Has the pandemic at all affected the way you're enrolling people, or has it caused you to slow down sort of your goals of when you'd like to get to that 1 million cohorts?
Like most all cohort programs and scientific research studies, we have had to adjust for the pandemic. And one of the things we did is first representing safety as job one. We stopped our in-person activities in March. And so sites moved to use telehealth for recruitment activities and calling participants and engaging with them virtually. And we're working on telehealth abilities to engage folks in research studies. However, our activities electronically have continued. So we started a number of activities specific for COVID-19. 3 major efforts. One was a serology study that looks at exposure to the virus potentially in early 2020. Potentially we could go back even as far as late 2019. Another was a survey that we launched that specifically looks at COVID-19 effects, not just the effects of maybe having the illness, but also the mental health effects, the effects on social environment discrimination, and the stressors that one may face due to economic hardship and social distancing. And then finally, we've been looking to ways that we can improve the electronic health records that we receive from participants, so that the data we get from those adequately represents COVID-19 testing, COVID-19 diagnoses, and their impacts. This is a new disease, so it's created new elements in the medical record. And so we want to make sure we capture those well. And those kinds of learnings actually are applicable to all the electronic health record systems really across the country, and some of the other efforts that the NIH is engaged in.
Well, and to your point, I know an ambassador for All of Us recently said that this project, All of Us, was really designed for something like COVID. What did he mean by that?
Thank you. Our participant ambassadors are a really important part of our program and really help us think about our directions. COVID-19 affects everyone, and especially it affects populations of color, and it's laid bare some of the health disparities, inequities that have haunted America for some time. And so, not only do we have a large population, but our population is very diverse. Over 50% of our population are racial and ethnic minorities, and over 80% represent a population that is underrepresented in biomedical research. We feel that enrolling populations that are diverse is really empowering and a scientific imperative, but it's also just the right thing to do. And the widespread impact across so many health conditions is the kind of thing that all of us is designed to do. And we have such longitudinal follow-up on our participants that, we, as participants are exposed to COVID-19, either directly or, through the psychological impact of what we're all going through, we will have that longitudinal impact and follow-up to know the outcomes of COVID-19 long-term as well.
Well, and one of the things I know that's so exciting, that has excited me about All of Us, is just this idea of personalized medicine. Do you see personalized medicine as playing a role at all in COVID treatments? I know this is something, there's a lot of work and research being done on, how patients with serious illness can be cared for, but do we see any of that research kind of in the area of personalized medicine?
Personalized medicine has been a long focus of my career, and we typically think of that as common diseases, cardiovascular disease, treat blood thinners, but we always, as physicians, have sought to, personalize our treatment for our patients, and the first step in that is understanding the disease. And we're dealing with a public health crisis right now, but within that we have differential outcomes with COVID-19. The degree to which the thrombotic complications, cardiovascular complications, these don't always aren't always predicted just by simple demographics of age. And we don't really understand the interplay between different diseases. And certainly they're beginning to show some genetic findings, such as blood type. And there's some other genetic signals that may play out as well. And so having a rich data set like ours that also has for instance, in our case, whole genome sequencing will be part of for all of our participants, will be one of those important factors to help us understand the impacts of the disease. And then we'll also be able to look at the outcomes. And so that will help us longer term see maybe not just the immediate outcomes, but longer term outcomes as well. So I believe that just COVID-19, like really most diseases, could have an aspect for personalized medicine in terms of better treatments, better understanding of prognosis, and individualization of care.
Well, you alluded to this earlier, but one of the goals of All of Us is, I know, to enroll more people from minority communities, because research has typically skewed towards people who are white, male, and better off. Can you talk a little bit about that effort to enroll a diverse population and what you've done to ensure that?
Thank you, Paige. Enrolling diverse populations is so important. If you look at all of our genetic studies so far, about 4% of those look at populations that represent about a third of America. So we have a long way to go. And similar study and diversity lacks are seen in a lot of clinical trials. We believe that all of us can really help bridge that gap. And I'm a data guy, and I've been told, always heard the message that this is hard, but and it is, but it's not insurmountable. It's really important that you partner with your participants. Participants have been part of this project, community groups, engagement events across the country. We did this all at the very beginning, and these folks partner with us in all level of governance, We listen as we engage these efforts. We have community advisory boards with each of our recruitment sites, and then try to engage authentically. And it's really important that you seek to return value. So what is meaningful to return to your participants? And that's a big part of our program as well. We're going to return information to them, and our participants have told us, for instance, that knowing the health effects of some of the genetic changes that an individual might have put them at risk for future risk of breast cancer or cardiac arrhythmias. Those kinds of data are the kind of data that participants would love to have back. And so, we're working to return that kind of information to folks who enroll in our program.
What are some of the biggest concerns that your folks hear as they're trying to convince people to, contribute personal medical information to this project? I would imagine some people are worried about privacy. But what are the concerns that you hear most often, in particular on the privacy front? What are you doing to try to alleviate those concerns?
You hit the nail on the head. Privacy and security are really one of the primary ones. And, we have always felt that security and privacy of the data that people are willing to share with us and donate is job one. Security and privacy really have to be job one. And if you don't get that right, you can't build on that. You don't have transparency and trust. And so we want to be honest with our participants with the whole process, and let them know what we're doing to protect their data. And we engage outside firms to test us, to what we call white hat hackers, to try to test and find security holes, as well as a lot of continuous top of class systems and testing of our systems and continuous monitoring. As well, transparency about what you're doing with their data is really important. So we have worked really hard on what we believe is a very clear consent process, and a series of questions afterwards, so people understand what's happening to their data. And we think it's really important for discovery, and our participants agree when we've talked to them, that these data have to get out to as broad a research audience as possible, because transformation and discovery happens from lots of smart people engaging and asking questions of a large data set. And so by creating safe ways to do this kinds of investigations, we think we can accelerate discovery and lead to better understandings of disease, which ultimately should lead to better treatment.
And how are you guys doing on your goal to reach those 1 million enrollees? Are things going along according to schedule?
Well, things were going really well until COVID-19 hit. And we paused our in-person activity. So we had been enrolling at a pace of around 3,000 or so people per week, making it through all the steps of the program. And that's really one of the, when you consider the depth of our program and what participants provide with answering surveys, donating blood, urine, sharing their electronic health records, and a brief in-person physical exam, that's really a remarkable recruitment rate. We still have patients that are coming to the website, and our program is still open. Joinallofus.org. Anyone can sign up, people are still joining online, but we just have to wait for some of our in-person activities to resume. So we're looking forward to that, and we're actually exploring new ways of doing that that are safe in COVID-19, potentially using saliva, and looking at patients that are otherwise in a healthcare system. And some of our sites are exploring some novel ways of recruiting as well. So business as usual will take a while to resume, but as we all know, which we're all looking forward to, but we are adapting to the situation as well.
Well, and I know a lot of people had to put off doctor's visits this spring, and there's probably a backlog there. So yeah, every corner of the country kind of being affected. Add one last question I wanted to throw at you, and I hear this concern a lot, amid all of the excitement about targeted treatments and personalized medicine. That also kind of brings concerns of cost, which already kind of plague the US healthcare system, but kind of this idea that you're getting a treatment that's highly targeted to you, but may not be useful to other people, and what that could mean for your bill. Can you talk about that a little bit? Is that something that worries you if personalized medicine is more broadly adopted in the future?
Certainly. There are a lot of stories of certain, for instance, cancer therapies that are have maybe remarkable effects that are hyper targeted, and there's a couple of responses to that. One, not all personalized medicine does lead to increased cost. If you can think about the colon cancer screening or breast cancer screening recommendations that were just talked about in the last segment, if we better knew an individual's risk and who needs to be screened earlier, and maybe who could be screened later, or maybe with less aggressive methods. Some of that could actually lead to reduced costs, and certainly the prevention of cardiovascular disease and breast cancer and colon cancer are huge cost savings to the system. Additionally, it doesn't always lead to more expensive medications. So one of the examples I like from the cardiovascular story is platelet drugs given after cardiovascular stents are placed after myocardial infarction. There are medications that are off patent that are generic and cheaper that can be used in a lot of the population based on genetic variants. And so, knowing who you can target what medications to can actually sometimes lead to cheaper therapies that actually lead to equivalent results. And there's some randomized control trials that support some of that as well. And so I think personalized medicine, as it leads to better care, ultimately leads to healthier people and prevention of disease on a health trajectory that doesn't always lead to increased cost, and hopefully leads to a healthier population for sure.
Well, that's all the time we have today with Dr. Josh Denny. Dr. Denny, thank you so much for joining us today.
Thank you so much, Paige.
Please stay tuned. I will be back in just a minute with 23andMe CEO Anne Wojcicki. If you're just joining us, I'm Paige Winfield Cunningham, a health policy reporter here at the Washington Post, and I'm delighted to introduce our next guest. She's the CEO and co-founder of 23andMe, Anne Wojcicki. Welcome.
Thank you. Thanks for having me.
Want to talk about COVID starting out, of course, because what else do we think about these days? I know that 23andMe launched a study in April looking at genetic factors that could affect the severity of COVID-19 symptoms. Can you tell us a little bit about that study and even share some preliminary results if you have them?
Mm-hmm. We launched a study on April 6th, and I'm really excited. We have now over 1 million people who have taken that online survey. We have over 20,000 individuals who said that they have had COVID and were sick. And we have thousands who also said that they had been hospitalized. So we've been able to actually look through quite a bit of data, and we have a couple interesting findings. The first one, which we talked quite a bit about, was the ABO finding in blood type, and that O actually looks protective. The second, it looks protective, and it's anywhere from sort of a 6 to 20% sort of decrease in severity and likelihood of susceptibility. The other aspect that is really interesting is sort of this question of ethnicity, and why is it that some communities are much harder hit. And even when we looked at the data and we adjust for sex, income, health, pre-existing conditions, we still see that Blacks and Latinos are significantly higher risk for being hospitalized than European white communities. And I think that's something that we really need to have the entire academic research world be able to come together, because to get the statistical findings that we need larger data sets. But it definitely looks like there's important research to be done there.
Well, and we know data, to your point, like this is really, really important for understanding the virus, who it's affecting and how it's affecting them. Do you plan on expanding your database at all? And are you working with the CDC or other government agencies to share any of this information?
We're continuously expanding. We actually launched a program about a month after we initially had the surveys, saying that we're giving away up to 10,000 free kits for anybody who had COVID-19 and was hospitalized and they're not already a customer. So we are trying to expand it organically by just giving out kits. We are looking to work with a number of different academic groups, the CDC, anyone who actually wants to help partner on research. We're absolutely open to that. So we have been reaching out to a number of different groups, and as these data is collected, we will be part of those studies.
It seems like this is such an opportunity for 23andMe to play this role in providing this great data in research. Is this something you had anticipated? Is this the type of activity you had sort of anticipated being able to participate in? Obviously, you couldn't have foreseen that there would be a coronavirus pandemic, but it seems as though you're pretty well positioned in this moment to contribute to the research.
Well, one of the things that when we started the company, we always said, it's kind of crazy that to do a clinical study, or if you're in an academic center, you have to spend so much of your resources on recruiting individuals, bringing them into the study, sort of setting up the entire study. And 23andMe was started with the premise that we want to have a community of people who are just there and ready to answer questions and want to have opted into research. And in this case, I'm really proud of the 23andMe community where, we have over 12 million customers now. We put out this survey. We got, 1 million people very rapidly to take this. We already have genetic information on them. We have, a number of these customers have already opted in and given us additional phenotypic information about them. So we had what we call sort of, research on demand, like almost that ability to just, log into the computer and Google anything. We had this ability to reach out to our customers, put out a survey rapidly and collect information and make a discovery. And I think, as the previous speakers had talked about, there's a real importance in having a nationwide surveillance system. And in the absence of having anything like that, 23andMe provides this ability to get real-time answers on really important medical questions. So when there is a question, we have that ability to put out a survey, send it to customers who have opted into research, and get an answer relatively quickly and inexpensively.
I want to take an audience question that we received, and I know Dr. Denny and I talked about this issue as well, and that is privacy. Connie DeMary from New York says, how do you ensure patient customer privacy at 23andMe?
Privacy has always been a top priority for the company. And we said in the earliest days that we can't really have a business unless we can do everything we can to protect the privacy of our customers. And we spent a lot of time with privacy experts in the earliest days. And what they taught me was that privacy is defined by choice. People want to have the choice about how they want to share their data or not share their data. And what 23andMe, if you look at our consent form and everything we've done, we want to give people options to say, you have the ability to share with your family, you have the ability to share with your doctor, you have the ability to download your data if you want it. But if you never want to share and you never want to consent for research, and if you want to delete your data, you absolutely have all of those rights. And so privacy and choice have always been top priorities for the company since day one. And it's something that I'm hopeful that as a leader really in digital health and having millions of individuals, that we can set a trend actually for the entire healthcare system to give people more choice and more transparency about how their data is actually being used.
To that end, Congress is working on legislation to protect patient information for health data that's gathered on wearables like Fitbits or phone apps. Can you give us your thoughts on that? Is that a good thing? And is there any point at which you're worried about overregulation?
I think I haven't looked at that in detail. I think that the most important things, it's kind of what I said. I think that people need to have choice and transparency. When I think about 23andMe and I talk about our research initiatives, over 80% of our customers opt in. And once you've opted in and you're taking a survey, at the top of the survey, it reminds you you're opted into research. And I think it's really important for people to understand and to know what those choices are, what the decisions are that they've made, and how is information being used. And I think as we're getting all of this digital data and you have wearables and you have your phone, I want to know what's happening with that. And I think it's really important for all those companies to be really transparent. But almost more than that, I look at like the existing system that's there, like when I go and I pick up a prescription at a pharmacy, or I go to, get a mammogram at the hospital, or I have a biopsy or something. All that information, when I sign the consent form at a major hospital, there's no transparency really about what that happens. And I think that not just looking at digital care, but I think looking at the whole system, I think there needs to be that kind of transparency.
The pandemic, of course, has had a devastating effect on the economy and on businesses through the lockdowns, and consumer spending is down and such. I know that your own company recently laid off 100 people. Can you talk a little bit about how the economic turmoil has affected 23andMe?
It's interesting. We had 23andMe has reached a level of popularity and we're part of the common day vernacular. People talk about their ancestry results, they talk about Neanderthal, and yet in 2019, sales really slowed. And my only hypothesis as to why was actually from privacy, which I can understand. People look at the Cambridge Analytica issues, they look at other privacy breaches that happen, and they said, I just want to pause. I want to understand how information is being used. And then obviously we come to 2020, and sales definitely slowed in that early March phase, which was after our layoffs. And again, the layoffs really came from sort of the 2019 kind of slowdown, but sales have really picked back up. And I'm always, I definitely am surprised at how much the sales have picked back up, and the economy seems to be robust. When I talk to other consumer companies, they are definitely seeing, a steadying state that has frankly surprised us.
Well, and I could sort of see it both ways, I guess. I mean, on one hand, people have generally less disposable income and perhaps, lots of worries about school and work and such. On the other hand, people are more interested in data about their health as they think about the threat of the coronavirus. Wanted to ask you about a slightly different topic, and that is the Black Lives Matter protests. I know that on June 2nd, you wrote an open letter expressing support for Black Lives Matter. And in that letter, you said you didn't actually have any Black employees above the director level. I'm wondering if you've made any changes since then, or how you might go about changing the demographic of your workforce.
It's a really important initiative for the company. And I think the Black Lives Matters movement really, I think, impacted everyone at the company and made people step back to say, as much as we have the right types of intentions, we need to relook at how we're doing things. And that looks at our hiring practices, our potentially microaggressions within the company, who are we partnering with? And I think it was sort of a moment to reflect that, again, despite the right intentions, we have to change something, because the output and the end result of what we're doing is not right. So we definitely we have been really full force looking at what can we do with our hiring practices, our culture, having looking at the types of partners that we have. I am really pleased to say we hired a new head of our medical affairs team, a VP medical affairs and clinical operations, who is of African descent. He's phenomenal, Dr. Oki, I can't say his full last name yet, and is a phenomenal hire for us. And we're looking at other aspects of the company where, every hire that is coming in the door, I want to make sure that we have the right type of approach for that so that we're getting diversity.
I wanted to ask you about advertising as well. I know that 23andMe doesn't currently allow companies to advertise to customers on your website, but I'm wondering, is it something you consider in the future? Obviously, this is something that happens all the time with Google and Facebook.
We've always taken the approach at what's in the best interest for our customers. And I'm really, when people ask, who's your customer, and you have pharma partnerships, you have others, like at the end of the day, the most important thing that I always think about is, as a customer, would I want this experience? Is this in the best interest for me? And I think about advertising, and I'm not sure that I want my personal genetic experience to have ads. I don't think it's the right direction for the company. That said, there are times where we identify people who have a very rare condition, and do we want to connect them to a clinical study? Do we want to connect them to information about therapies that are out there? When I feel like it's a potential service that we are giving to our customers, we can put that into the research bucket, and we can say, yes, we can potentially do a research study here, but we are not advertising based on genetics, and I do not anticipate having ads within the 23andMe experience.
Well, unfortunately, that's all the time we have for today. I want to thank all of my guests, Dr. Tom Frieden, Dr. Josh Denny, and Ann Wojcicki, for being with us today. We'll have all the show interviews and highlights posted online in a few hours at washpostlive.com. At 3 p.m. Eastern, we'll be back online with Washington Post Live, where my colleague Eugene Scott will be interviewing Spelman College President Mary Schmidt-Campbell and Irene Pollard, the president of Montgomery College. I'm Paige Winfield, Cunningham. Thanks so much for watching.